Diagnosis of myocardial infarction/ischemia with bundle branch blocks. Mark Eilendorf, MD, MHP, FACE, FEM, RDMS. Chair and Associate Residency Director, Medical Director, Department of Emergency Medicine, University of California, Irvine. Objectives: to understand the interpretation of 12-lead ECG with regard to infarction, ischemia, in the presence of right bundle branch block, left bundle branch block, ventricular paced rhythms. To understand the utility of decision rules on this topic, take-home messages. You can make the diagnosis of acute myocardial infarction or ischemia in the face of bundle branch blocks or paced rhythm. Secondary SDT wave changes are normal, and go in the opposite direction of the last portion of the QRS complex. Primary SDT wave changes mean ischemic or infarction, and go in the same direction as the last portion of the QRS complex. Take-home messages. Left bundle branch block that is new or not known to be old, in the setting of a clinical picture of me, likely indicates infarction. Reperfusion therapy is recommended. Serial ECGs may clarify the situation. Immediate angiogram is preferred. Cardiac induction system. Bachmann's bundle. Sinus node. Internodal pathways. Left bundle branch. Avenue node. Bundle of his. Posterior division. Anterior division. Purkinje fibers. Right bundle branch. Truth: the diagnosis of myocardial infarction in the presence of left bundle branch block is impossible. Partially true. True: diagnosis of complete in me and left bundle branch block is difficult. Q waves may be present with LVBB in the precordial leads without anterior infarction. SD segment elevation can be hidden in the usual repolarization changes. But, Q waves in two contiguous lateral leads suggest complete in me. R wave regression from V1-V4 suggests transmural necrosis. But, ongoing ischemia and injury can be detected in the presence of LBBB, and may be seen as often as they are in the presence of normal cardiac induction. Comparison with old ECGs helpful. Serial ECGs while in the ED also helpful. Fessmeyer, Annals M, 2669, 1995, Dr. Braunwald says. Some findings are highly specific and predictive, 90 to 100%, for me with left bundle branch block. Q waves in at least two contiguous lateral leads, AVL, V5 and V6. R wave regression from V1 to V4. Primary SDT wave changes in two or more contiguous leads. SDT wave changes with bundle branch blocks. Changes are the same with both right and left. Also applies to LVH with strain. Secondary means normal, expected. Primary means abnormal, ischemia or infarction, terminal portion of QRS. J point. ST segment. Terminal portion of QRS. Secondary SDT wave changes. These are normal, expected. Terminal portion of the QRS complex is a key. J point displaced away from the terminal portion of the QRS complex. T wave oriented away from the terminal portion of the QRS complex. Primary SDT wave changes. Primary equals abnormal, not a result of BBB. ST elevation still means injury or infarction. ST depression still means ischemia. Exceptions: Prinzmetal's angina, reversible ST elevation. ST depression/T wave inversion can represent infarction, subendocardial or non-Q wave. Primary SDT wave changes must be in two contiguous leads. Inferior. 2 and AVF. 3 and AVF. Not 2 and 3. Septal, V1 and V2. Anterior, V3 and V4. Lateral, V5, V6, I and AVL, high lateral. Primary SDT wave changes. One major caveat. Allowed one lead that is concordant terminal QRS complex in T wave. QRS changes from predominantly positive deflection to predominantly negative. Don't infer ischemia/infarction if only one lead. Concept of dis/concordance refers to whether the last portion of the QRS complex goes in the same or different direction as the T wave. Discordance equals good. Concordance equals bad. ACG of evolving me with left bundle branch block. Review of 26,003 Gusto patients, 1993. Derivation set, 131, 0.5%, patients with left bundle branch block. Average time from onset of symptoms to ECG, 120 minutes. Validation set, 45 patients from Gusto 2A with AMI and LBBB. Scarbosset et al., Lane, 334-481, 1996. ACG of evolving me with left bundle branch block. Identified 3 predictive criteria. SD segment elevation greater than 1 mm concordant with QRS. SD segment depression greater than 1 mm concordant with QRS. SD segment elevation discordant with QRS. How did these factors perform on the validation set? ACG of evolving me with LBBB. SD elevation greater than 1 mm concordant with QRS. Sensitivity, 73%. Specificity, 92%. Odds ratio 25.2, 95% C 11.6 to 54.7. ST depression greater than 1 mm concordant with QRS. Sensitivity, 25%. Odds ratio, 6.0, 95% C 1.9 to 19.3, ACG of evolving me with left bundle branch block. SD elevation greater than 5 mm discordant with QRS. Sensitivity, 26%. Specificity, 92%. Odds ratio, 4.3, 95% C 1.8 to 10.6. Decision tree incorporates all 3 factors in order of predictive power. ACG of evolving me with left bundle branch block. Does a T wave go the wrong way up? Does a T wave go the wrong way down? Does a T wave/SD segment go the right way, but too far? 3 yes answers equals 100% me. 3 no answers equals 16% me. Probability of me percent 192 93 88 166 50 16. Right bundle branch block in V1. Up down. Secondary normal STT wave changes. Right bundle branch block in V6. Down up. Secondary normal STT wave changes. Left bundle branch block V1. Down up. Secondary normal STT wave changes. Left bundle branch block V6. Up down. Secondary normal STT wave changes. Right bundle branch block V1. Up up. Primary infarction STT wave changes. Right bundle branch block V6. Down down. Primary ischemic STT wave changes. Left bundle branch block V1. Down down. Primary ischemic STT wave changes. Left bundle branch block V6. Up up. Secondary infarction STT wave changes. Left bundle branch block V1. Greater than 5 mm. Too far up. Primary infarction STT wave change. Exaggerated SD segment elevation. Right bundle branch block with secondary STT wave changes. Left bundle branch block with secondary STT wave changes. right ventricular paced rhythm with LBBB pattern, secondary SDT wave changes, RBBB with interoceptal ischemia, RBBB with interoceptal infarction, LBBB with exaggerated SD elevation, interoceptal/lateral infarction, LBBB with lateral infarction, left bundle branch block with interoceptal ischemia, left bundle branch block, primary STT wave depression, primary STT wave elevation, exaggerated SD segment elevation. Are these criteria valid? Poor performance. 190 patients /13% with AMI. Sensitivity, 0 to 16%. Specificity, 93 to 100%. Treat all LBBB not known to be old as acute ME. Good performance. 224 patients /45% with AMI. Sensitivity, 73%, cardiologist, versus 67%, EP. Specificity, 98%, both. Lee, et al., Annals M, 36 to 561, 2000. Sokolov, et al., Annals M, 36 to 566, 2000. ACG of evolving me with LBBB. 414 ECGs with AMI and LBBB, 85 with LBBB without AMI. Prevalence of findings. Concordant ST segment elevation, 6.3%. Concordant ST segment depression, 3.1%. Discordant ST segment elevation, 19.0%. Concordant SD elevation and SD depression in V1 V3 were highly specific for diagnosis of AMI. Gila LJ et al., Coronary artery dis. 14 to 387 to 93, 2003. ACG of LBBB without MI when 24 patients with LBBB and no ME. Only one had primary SD segment depression anteriorly. Only one had primary SD segment elevation. 9 had exaggerated stream segment elevation greater than 5 mm. Scar-Bossy criteria are sufficiently specific, few false positives. Matthias J., et al., Myocardial, 24 to 652 to 5, 2001. ACG of evolving me with LBBB. 182 patients with LBBB and acute ME. New LBBB, SENS equals 46%, SPEC equals 65%. Concordant ST segment elevation or depression, Scar-Bossy criteria. Specificity equals 100%. Positive predictive values equals 100%. Sensitivity for ST elevation equals 8%. Sensitivity for ST depression equals 17%. Of patients with acute ME and LBBB, only in 46% of them was the LBBB new from their ME. Conversely, only 65% of patients with new LBBB actually had ME. So, if we treated everyone with new LBBB and chest pain, we'd treat 35% unnecessarily. If we only treated new LBBB, we'd miss treating 54% of patients who needed it. Condos MC, et al., and EMERG Med. 37 to 431 to 8, 2001. ACG of evolving me with LBBB. Of patients with acute ME and LBBB, the LBBB was new, from their ME, and only 46%. If we only treated new LBBB, we'd miss treating 54% of patients who needed it. Conversely, only 65% of patients with new LBBB actually had ME. So, if we treated everyone with new LBBB and chest pain, we'd treat 35% unnecessarily. Should we treat all patients? American Heart Association. Literature, not necessarily. 35% with new LBBB and chest pain did not have an ME, condos. 48% with LBBB not known to be old did not have an ME, et al. Scarbossi criteria are helpful. If present, thrombolytics indicated. If absent, serial ECGs or catheterization. Yes. Edhouse, et al., J. Axodemrg med. 16-331-5, 1999. Take-home messages. You can make the diagnosis of acute myocardial infarction or ischemia in the face of bundle branch blocks or paced rhythm. Secondary SDT wave changes are normal, and go in the opposite direction of the last portion of the QRS complex. Primary SDT wave changes mean ischemic or infarction, and go in the same direction as the last portion of the QRS complex.